I am thrilled to introduce in a moment to you Dr. Georges Benjamin. Our Grand Rounds is really a collaborative effort. So this is an effort with our own brand new chapter of Delta Omega, who are the co-sponsors of Grand Rounds. So we are very happy to have the Delta Omega students and faculty engaged. We're also presenting this on behalf of our Public Health Training Center. We're now a partner with Johns Hopkins on a Public Health Training Center. So this is one of our training center activities. So it's really a thrill to introduce Dr. Georges Benjamin. For many of you, Dr. Benjamin is probably the face you see of the American Public Health Association. He has been the executive director there, and it is our nation's largest public health organization. He's also served as well in the state of Maryland, and he was the secretary of the Department of Health and Mental Hygiene from 1999 to 2002. He was the Deputy Secretary for Public Health Services prior to that for 4 years. But for more than 20 years, he has been a public health practitioner at the local level, the state level, and the national level. He has an area of expertise in infectious diseases, in emergency preparedness, and public health administration. As many of us know, he serves as the publisher for the American Journal of Public Health and our premier journal in the field, The Nation's Health, and the APHA publication on infectious diseases, the Communicable Diseases Manual. He is a graduate of the Institute of Technology, Illinois Institute of Technology, and the University of Illinois College of Medicine, and he's a board-certified internal medicine. He's a fellow of the American College of Physicians, and then this list of honors gets pretty long and impressive. The Fellow Emeritus of the American College of Emergency Physicians, an honorary fellow of the Royal Society of Public Health, a fellow of the National Academy of Public Administration, and a member of the Institute of Medicine of the National Academies. So he's also a public health advocate and serves on the board of Research America, Partnership for Prevention, and the Reagan-Udall Foundation for the FDA. He is an advocate, and so one of the things you will hear, and if you follow APHA's role in healthcare reform and in national policy, you will see his statement on Monday after the release of the president's budget, in which he says the failure to adequately invest across all areas of public health could hamper implementation of the Affordable Care Act and slam the brakes on future progress against the many threats to the public's health. So join me in welcoming Dr. Benjamin. He will speak and then he will take questions. When he takes questions, what we will do is have somebody roaming the audience with a mic. So raise your hand and we will get the mic to you.
Good afternoon, everyone. What I want to do today is just talk a little bit about kind of the environment that I see us in today. And I often start or end my presentations with this. Some of you know this person. This is Mom Smavely, and those of you who are of my age and older know that most of what Mom said you could not say at Black Company. But this is something that she said, and I think that it's absolutely true. And germane to our discussion this afternoon. And she said basically, you always do what you always did, but then you always do what you always got. And that's a fairly potent statement, because I think it's true. And I think that's something that we need to think about from a public health advocacy perspective, because a lot of what we're doing just doesn't seem like it's working. And I tell you this stuff, I tell you what the operating environment of public health is practicing. has dramatically changed. Obviously, the emphasis today is moving a little bit away from infectious diseases, more towards addressing chronic diseases. Health reform is playing a major role in how people think about the health system in the future. Obviously, we're going through a terrible, terrible economic time, and that restrained economy has impact on a lot of what we want to do in population health. We're getting older and much more diverse as a nation, and that has huge implications for health disparities and how we address healthy communities, things that this institution is very much involved in, both on the health disparities front as well as on the health literacy front. Things such as globalization, the fact that a single hamburger no longer comes from a single cow or a single farm, maybe not a single state or even maybe a single nation, has huge implications for tracking disease outbreaks, infectious disease outbreaks from that foodborne nature. A whole range of disruptive technology. I mean, who would have believed that in order to really be a functional, engaged citizen, you've got to have an iPad, an iPhone, and a bill, and then access to a range of computer-type toys, just to be able to talk to one another, and that many of those devices also are phones. And they just have terribly changed the way in which we communicate, in which we talk to one another. I mean, the idea that we no longer need to string phone lines in underserved communities, but we can send text messages through cell phones. That the cell phone is more likely, probably the most active communication device to many of our low-income communities. That may very well be an effective tool for us to begin to engage people to improve health and change behavior. It's an interesting idea whose time is going to come. And of course, the anti-government view in that country. We don't want government until we need government. We don't want to invest in government. And then when something bad happens, why didn't we invest in government? Whose fault is it? Who can we fire? Who can we blame? Forgetting the fact that we stood idly by when those resources were pulled away, which could make us healthy and protect us. So those are some of the things that are important. But there's some other things that I think are important. So the fact that ideology has definitely invaded our science. Okay, I was at APHA today. That the Surgeon General at that time spoke his mind out on tobacco, and they got yanked back to HHS and yelled at about saying what any doctor with any credibility would have said, and certainly in the Surgeon General, tobacco is a public enemy #1, leading cause of death. And if he could have a white sheet of paper and get rid of tobacco, he would. Okay. Any doctor who doesn't say that, any nurse who doesn't say that, in my view, is not true. And yet, politics continue to have science. People who last year said climate change was a threat, today say climate change is not a threat. All about ideology, all about politics. And we need to understand that we have a First Amendment, but we don't have the right for our own facts. So there's some issues here we have to address. We got enormously different views on cost cutting. Right? Depending on the party. And I'll just let that stand for itself. The court's always been a regulator, but increasingly the court's becoming a regulator. Right? So the court is a question about the court weighing in on the graphic labeling on tobacco packs. The court's increasingly become a regulator and a policymaker. And we're going to see probably in June how much impact the court will have in policymaking around basic health coverage in this country. This is a major issue, major policies. That's what the court's for. They're there to resolve disputes. But I think we have to begin thinking a lot more broadly about how we influence processes so that they become no-brainers for the court. The court can clearly decide on the merits of the law in line. So that means that regulations and things like that certainly are much more important today than they were before. Then we have the public. I'm a member of the public, and I certainly have different views. But I think it's important to understand that the public views are very complex. This very, very famous concept of, I don't want the government in my management. And I got to tell you, the more interesting part is when you really talk to the public that says that, they understand this is a government program. They understand it's a government program. But nonetheless, they still don't want the government in their management. And over the last 2 weeks, we've clearly seen the real challenges and the controversy, both around women's right to choose, regardless of which side of that discussion you're on, which is now expanded family planning. And I got to tell you, the problem that I have is I would have loved to see such activism around corporate, okay, as we're seeing around some of these wage issues. Can you imagine what would have happened had the church weighed in on Medicaid cuts? Or the church weighed in on health insurance in a more aggressive way? Or any other things, public health preparedness, or the $4 billion cut they're about to have in the prevention fund. I mean, we've got to begin to try to do a better job of educating a whole range of stakeholders and understand there's a whole range of other folks. And we've got to convince that the public's health is part of their responsibility, part of their area of interest. So we have some real work to do. Now, that means that just formulating public policy is going to be much more complex in the future as we go forward. And I remind people why government intervenes in public policy, right? It's the moral and ethical issue. People weigh in. Certainly health and safety issues are important. That's another reason why we use public policy. A market failure, or obviously the political views of the folks that have a range of power as a way of fixing what they think needs to be fixed through the ideology that they have. And ideology isn't bad. Okay. Having your views aren't bad. But just recognize that these are some of the reasons that we use public policy. And I argue that one of the main reasons we needed to do that was because we had a phenomenal market. We had rising costs, reducing access, poor quality, unequal access as well because of the major health disparities. And fundamentally, a system which wanted to pay millions and trillions of dollars to fix things after they got broken, but didn't want to spend anything to keep things from happening. So we know that public policy is a very, very helpful health improvement tool. We know that. We know that there are many levers that both government and non-governmental entities have to try to put public policy in place. And there's an amazing role for the public as part of that process. We're going to talk a little bit about it. Now, sometimes I go into public health groups, and we get into this big debate about whether or not health insurance is a public health intervention. And I got to tell you it is. We know that simply the absence of health insurance is responsible for about 44,000 lives, premature lives lost each year. We also know that it isn't everything, but health insurance is important. And having been an ER doc, I know that you need to get into the system card. Okay? You don't have to get into the system card, you don't get into the system. And we talk all about the safety net, and we have free clinics and community health centers, and those are all wonderful, and I support every single one of them. But even in those situations, you need to get into the system. Okay? If you're not a member of the club, you have enormous barriers moving through the system in a smooth manner. In fact, if you got a card today, you got trouble moving through the system anyway. But if you don't have a card, it's even worse. So it's important to understand that health insurance is a really a public health issue. And the good thing about the Affordable Care Act is that it puts in place some very, very important clinical preventive services, from requiring first-dollar coverage to a range of screening tests, to ensuring that people, primary care providers are in place, which are enhancing the primary care provider pool. There are many things in that legislation to begin to reboot our system much more so towards prevention, which I think are important. In fact, the national debate we just had in the last 2 years, the last 2 weeks, was fundamentally about access to preventive services. That's what it's really big about. It's about access to preventive services. So that's important for us to think about the fact that there are some very important components of that legislation, which I think we ought to pay attention to. Of course, those of us in public health know that health is, and wellness is about a lot more than an insurance coverage. It's about risky behavior. So it's about access to tobacco. We know that tragically, most people who initiate tobacco use do so when they're young. And so this is a big deal for us to engage in reducing risky behavior. And there are lots of interventions. We've got both individual and community-based interventions that we know work. They're proven interventions. Some of them are policy interventions. Some of them are clinical interventions. And in many ways, some of the policy interventions have a lot more impact to the population than some of the individual interventions. I mean, putting in a smoke-free law so you can't smoke in bars and restaurants can have enormous benefit to the population. Or you can decide you want to try to stop each and single one of those persons from smoking, ideally preventing them from smoking in the first place. But preventing conditions that people don't want to smoke is very, very important. Health is about what we eat, right? And we've talked a great deal. We've talked a great deal in the public health community about the amount of sugar that's in sodas. I love these things, like most folks. But it's not just about what you drink, but it's how many of them you drink. And we're being marketed to. Now, some would argue that, well, we also have sugar in orange juice and other juices. But I have not yet seen, although I don't want to necessarily know what the film saying this, but not yet seen the fast food stores promoting a 32-ounce thing of orange juice. So they do that here, okay? So this is our challenge. This is our challenge. And we've got to figure out how to make folks understand that there are alternatives. So there are many alternatives in terms of access. We know actually when you give children healthy access to healthy foods, they do make different choices. Even some of adults do as well. So there's lots of things that we can do about changing what we eat and how much we eat. And one of those things, of course, is around nutritional labeling. I'm amazed as I begin to look at nutritional labeling. And a number of times I've talked to people about, do you want a donut or do you want a bagel? And which really has the most calories? Which is a, nice simple donut. I'm not talking about the stuff that some of you are thinking about. All the cream and the sprinkles and all that. I'm talking about a nice, small cake donut with a bagel. Of course, a bagel, you can't just eat a bagel. You gotta have cheese on it, right? And think about what else you want. But think about the number of people who are on their diet, who come in every day, bring in a bagel, lots of stuff on that bagel. Then they pull out the salad, because they want to eat healthy. And I'm sure they're getting their referees, but I can tell you, the ham and the cheese and the dressing and all the other stuff on that salad, it's not necessarily what they think they're eating. And when you go to a restaurant, portion size and one of the reasons for putting calorie counts are to give people the opportunity to make informed decisions. We often get people would say, well, it's a nanny factor, okay? It's health education, okay? And that's what we should be doing as public health practitioners. And when someone says you're nagging them, so that's what you're supposed to do. That's your job, okay? And it's about educating people, about giving them information, and then they have to make the informed decisions. If you don't inform them, they don't have the opportunity to make those decisions. This is an example. So we often get asked if these things work. So this is actually hot off the press. Just came out in JAMA. It's an article looking at trans fats, which actually has shown, this study was pretty narrow, it's in white men, but it basically showed that labeling, probably with some enforcement, can reduce exposure to trans fats and actually affect what we do believe one of the major determinants of cardiovascular disease. So labeling with some enforcement makes a difference. Huge policy implication as we go forward. Health is about equitable access to affordable foods. And everybody understands the concept now of food deserts. And this is a big issue. I know when I was practicing both in ER as well as my training in internal medicine, we were always pleased with ourselves when we had someone who was overweight that came in, and we sent them off to the dietitian, nutritionist, and gave them wonderful advice on how they should consume food. And then they would come back in, and of course, they hadn't lost a pound. And they tried. They've been struggling. They tried. But we also didn't ask the next question. Could you get access to affordable foods? And in many communities, particularly in low-income communities, that's just not enough. So that's something we need to, again, to address on a community basis. Now, this is a neat thing. I got to go to the White House when the First Lady rolled this out. This is the Let's Move initiative, the Healthy Food Access Initiative, where they brought together with a couple other groups in the health space, these major businesses who have now made commitments to moving fresh fruits and vegetables, theoretically affordable fresh fruits and vegetables, into many low-income communities. And I think this is a real leadership function, not only on the part of the First Lady, but also on these groups that have been working very hard. And these business leaders ought to be commended for going to those communities and finding a way. Now, are they there because they think they'll make money? Absolutely. Absolutely. Or people got money too. But the idea of changing the business model to bring fresh fruits and vegetables, to improve the health and well-being of these communities is an important step that we ought to support. Health is about what we dump our trash. So I often talk about this. I remember when I was the health officer in Washington, D.C., and my predecessor, one of the public health innovations that we got involved with was putting police officers on the 14th Street Bridge. And that was to prevent trash haulers from coming in Virginia across the 14th Street Bridge, turning right in toward 8th in Washington, D.C., poor part of the town at that time, and dumping trash in the vacant lots. I always cynically asked, why didn't you turn left and go to Georgetown and dump the trash? You probably figured that one out for yourselves. But that's what they did. And so after putting police officers to periodically man the bridges to stop illegal dumpers and haulers is a public health intervention. But also paying attention to where we're zoning for trash dumps and our important public health interventions as well. And so we as practitioners have to think about where we're putting businesses. What are those businesses going to release into the environment? Where we're going to dump our trash. All those things are very important, and public health plays a role in advising government and advising development communities, and on occasion regulating that activity when they're within your regulatory authority. to make sure that we don't put these trash dumps right next to the community, or then build communities right on top of these old trash dumps without them being properly cleaned up. Now we also know that health is about ensuring safe water, safe air, and safe food. And that's pretty much the basics of what we do in public health. There's no question that we do that in public health every day. And we do that through a variety of tools, methodologies, engagements. But it's very important. I needed to say that because we often get so hung up in worrying about obesity and exercise and tobacco that we forget some of these core functions. We just want to make sure that we don't forget about those core functions. And in general, our function here is often in the regulatory realm. And we get a lot of pushback about regulation. People say, well, health regulations kill jobs. No, health regulations save lives. Okay? And at least from our perspective, that's important. And actually, if you actually look at what the employers say, if you actually look at the data, look at the facts, the employers actually say that's not why they don't hire you, because of regulations. You actually look at the data, that's not what they're, outside the political environment, that's not what they're saying. It's really causing them not to hire you. So it's important that we understand and not run for cover as soon as someone says that regulations cost jobs. Can they? Of course they can. But like anything else in population health, sometimes you have job loss on the left side, and then you have job creation on the right side. And sometimes you have to look at the sum of those jobs, and the quality of those jobs, and whether or not the people are healthy enough to do those jobs. All that has to be mixed into the equation as we move forward. Dealing with the issue of sedentary lifestyle. So one of the pushbacks during the whole health care reform debate and actually afterwards has been the debate about jungle gyms. Whether or not the health department ought to be supporting the building of jungle gyms. Now, there's a huge amount of data, a huge amount of science around the fact that organized play and children that are in organized play are not only more healthy, but they have better mental health and they stay out of trouble. They stay out of a lot of trouble. Okay? They're supervised, they don't end up in gangs, and there's a reduction in the number of these children that end up in the juvenile justice system, and then as they mature into the adult criminal system. So I personally believe that jungle gyms are not only good for physical activity, but they're good for mental health, and they're good as an anti-crime tool. Now, you'll hear some that disagree with me, okay? But they're wrong. Pure and simple. Pure and simple. You know, the data is with me, the facts are with me, the experience is with me. And we know that this is true. And again, when they throw out these ideological concepts that we shouldn't do this, or we can't afford to do this, if we can't afford to invest in our kids, what can we afford to do? What can we afford to do? So I argue, I vigorously disagree with them when people say that. Obviously, we need to have access to quality, affordable housing. I mean, that goes without saying. You know, we've had enormously good experiences in Baltimore City in terms of getting healthy homes, improving the number of healthy homes in the city, focusing on lead exposure, focusing on cleaning up those homes in Baltimore City that were in toxic conditions. And so I personally have experience as a health official watching my colleagues and other health officers and community groups working aggressively on this area. It's very, very important for the health and well-being of our community. You know, health is about access to quality education. This is a graph. This is an up-to-date graph, and let me just point out that the higher of the four numbers is looking at infant mortality based on number of years that the mother has had education. 4.2 being someone who's had 16 or more years of education. And, you know, the interesting correlate is that maybe we should take some of our health dollars and spend it on education. Okay? I mean, you could, you know, the secret to infant mortality, I mean, not that we shouldn't do all the stuff we're doing, but maybe the secret of infant mortality is paying a lot more focus to maternal education. Maybe that's the secret, because we've been struggling with this for years. We've been really struggling with infant mortality for years. District of Columbia, we did everything possibly known to humankind around infant mortality. We had mom vans, we had respite centers, we had prenatal education, we had ads on TV, we had people walking mothers to maternal child centers, okay, in a struggling education system. So this resonates with me. Maybe we need to spend a lot more of our time focusing on education and coming with a linkage between education and health in a much more productive way. We're serious about dealing with infant mortality. But we know that health is about external and internal stressors, okay? So there are lots of these stressors that I think are important. There are lots of stresses in our lives. You know, if it's a person that has to work 3 jobs and take 2 buses to get to work, that's a stressor. It's a person who gets up every morning and is told by their boss that they're not worthy of the work that they're doing, or their spouse or loved one. That is stress, and told the same kind of thing. It's the well-established African-American or Hispanic male who goes into the store and has the clerk follow him around all the time. What I usually do is go out, come back in so I can have that experience one more time. I mean, there are lots of stresses in life, and we've got to deal with these. We don't want to blame the victim, but we understand that you know, high blood pressure certainly can be treated, but there are many things that cause high blood pressure that we got to address, and some of them are sociological that we have to address in a variety of ways. You know, health is about community capacity. It's about jobs, it's about transportation, it's about access to health care, it's about providers in the community of all types. It's about living in a relatively violence-free community. It's about parks and open space, kids getting out, walking out of your house and being able to go sit down somewhere so you can just have a cool-out moment and be away from parents, family, kids, TV, whatever. And there are some communities where you have an abundance of that, and you have some communities where you go outside, but you dodge bullets. And so those are real challenges that we have to deal with. Now, the ACA actually provides some important community health provisions. And I remind people that this bill is actually a marvelous, it's actually long now, a marvelous document in terms of providing a range of things around prevention and wellness, particularly around community prevention and wellness. From the investing in the community Preventive Health Services Task Force, Clinical Preventive Health Services Task Force, to actually trying to get the government to work and play well together and coordinate its activities. There's some amazing language in this law to try to move us in that direction. One of them was the first report out from the group that's looking at prevention and health promotion. This is a group headed by the Surgeon General. It's the National Health Promotion and Disease Prevention Council. And their first report said that we needed to address health and wellness using these broad tools, which are clearly within the public health domain, which we think are important. And then they recently came out last year with a much more detailed report, which has measures and outcomes and really tracks issues across agencies. So for the first time, by law, you have the Department of Transportation, and Agriculture Department, and the Health Department, and the Commerce Department, and 17 federal agencies sitting in the room trying to make sure that they're coordinating their activities so that what Agency A does doesn't undo what Agency B does. This is an important piece, and it's headed by the Surgeon General with all these other cabinet officials. It's an amazing process in which the President has said, I want you to use a health and all policies concept to improve the health of the American people. And this is an important thing, and I just want to encourage that we do that. This is the original legislation for the Prevention and Wellness Fund. Some of you may know. This is the President's original budget proposal that came out the other day, as well as some discussions going on in Congress today are marked at cutting this fund. We're trying to push back as hard as we can, as well as many, many other public health groups, on these cuts in the prevention fund. Nonetheless, the idea was for us to begin to build a sustainable funding source for public health, which could not be supplanted, but they figured out how to do it. But would, in essence, enhance the core programs in public health that we have today. And you can see how the appropriations, there's a mandatory appropriations. They don't have to go through the usual appropriations process. Ultimately, cultivating the $2 billion of new funding every year within the public health system. One of the other components of that, which is funded from this, is these community transformation grants. And then there was a real focused effort to focus on physical activity, nutrition, and tobacco as a way of trying to focus our efforts. If you think about it, if we address those three behaviors and health risks, right, getting people more active, getting them to eat better, and keeping people from smoking in the first place, then we can address probably the top 5 leading causes of death. Heart, strokes, cancer, diabetes. And if you want to add a little bit of funding to deal with substance abuse in there, you can deal with injury, okay? So there are opportunities there for us to address in a very focused way some of the leading causes of death. I don't want to take away from the need to deal with HIV and other infectious diseases, but this idea of beginning to target our efforts, target our funding to focus on these areas for maximum impact, and then couple that with strong policy initiatives, community-based policy initiatives, so the communities behind what happens here, so the communities demanding that they fix the lights, so the community demanding that those communities become walkable, bikeable, and green, okay? Demanding equity, so that the sidewalks get fixed in this poor community the same way the sidewalks get fixed in the more wealthy communities, so that people can for purpose. So not just they want to look good, but so people can actually walk and get around them. The health dividend there is amazing. We need to push that. Now to do that, of course, we have to have the public. Now one of the things that I learned when I was a health officer here in Maryland was the power of the public. I also learned this in Washington, D.C. Anyone ever try to close a school or a firehouse? Can't do it. Can you close the health department? Done without people. And we need to learn how to do that in public health. We need to know how to engage communities such that they're mad when the public health department gets closed. We also need to deal with this data that sits out there. So this is a fascinating. This was the Robert Johnson Foundation Commission on health disparities, basically, and they looked at a bunch of things. And I argue what the national outrage is. So those different colored lines are graphs of some of the metro lines in Washington, D.C. I always tell people I live up at the 81.3 mark in terms of life expectancy. The numbers at the top, the circles are numbers of life expectancy, and in the city there's 72. So it's like a 10-year, someplace a difference in life expectancy depending on where you want to live. Okay, and this is not a secret. Everybody knows it because we see it every day. But where's the outrage? Where's the outrage? All right? The nation's capital. Premature deaths all over the place. Where's the outrage? So we need to figure out ways to engage the public. And so we got to have accountability. All of us need to be part of that accountability measure. From myself, from you, elected officials, our parents, grandparents, cousins, uncles. All of us need to be engaged as part of this accountability. And this is something that APHA puts out every year with the United Health Foundation, Partnership for Prevention. And we do these annual health rankings. And one of the most fascinating things for me is that we've had lots of states that have moved up and around. Vermont happens to be at the top. They've been at the top for the last couple of years. They do things quite well there. They've got low numbers of uninsured. But they do still have some challenges. Like, for example, they still have some challenges on immunization. So just being at the top doesn't mean you don't have any challenges. But what bothers me is that people aren't consistently asking, why are we at the top and why are we at the bottom? And my concern is that some of those folks at the bottom have been at the bottom for a long time. And they're not asking, why are we at the bottom? They also crosswalk by the way. High numbers of uninsured and some other negative consequences. Yeah, it doesn't mean they don't do some things very well. They do. But we need to begin to, when these numbers come up, and these reports come up every year, we need to say, if this was a ranking on education or a ranking on crime, there would be hordes of people in the streets demanding accountability from the resource officer. And we need to have them do this around Congress. So, I always point out that public health does its best work when nothing happens. And that in many ways is our fundamental problem. So that we do our best work when nothing happens. We have not yet figured out how to tell the story of almost happened but we prevented it. Okay? We still have not yet quite figured out how to tell the prevention story. So I commend that to anybody who wants to do that. I challenge you to help us figure out how to tell the prevention story. That's a very, very important component of what we do. It also means that we have some new skills we need to develop as well as one new behavior. So these three skills, I think we need to very much strengthen our analytical skills around things like cost-benefit analysis and health impact assessments, so that we can talk about the impact of our work. Second, we need to improve leadership skills around political leadership skills, policy development skills, advocacy, and communication. Not just about risk communication anymore. It's about how do you effectively communicate a message to the right audience at the right time, realizing that now we have this blue state America, red state America, purple state America. We got to figure out how to talk to all three groups in ways in which they will hear our message and don't get turned off by the messages that we're delivering. Because they often want the same things, but we haven't quite figured out how to change that message. How do you get people to support things that are in their best interest and not support things that are not in their best interest? Okay? So that at least they're making an informed choice about what's in their best interest. So that's something that we certainly need to do, and we need to do a better job of engaging communities, getting communities engaged on this right at the beginning of the process, and not bringing them in so much as we often do at the end of the process. And then finally, I think we can't be silent anymore. The behavior that we have is we often ask for too much, too little money, too late, and we're not enough vigor or amplitude to make a difference. We've got to be loud, persistent, engaged, and right about the things that we care about in public health. We've got to make coherent arguments to people that are not necessarily interested in hearing coherent arguments. But I think we've had a lesson of that in the last 2 weeks. How the right issue, the right people, hearing the right issue, can totally change the politics of the situation. So the public health community has got to get much more focused in those efforts if we're going to really be successful in trying to improve the health. With that, I'll stop and I'll be happy to take any questions you might have.